In the specialist centres, we have multidisciplinary care. So every cancer patient has their case looked at by a multidisciplinary team of doctors, including radiologists, surgeons, oncologists, and so on, pathologists. And that means that everybody is a multidisciplinary approach to what's best for you.
The advantage of the health insurance companies is that they have a lot of information about processes in hospitals. So they see all the bills, they look at quality indicators, so they really can compare one hospital to the other and say, oh, this one is a good hospital.
The health sector is still lagging behind in terms of using really data to support policy-making processes.
So that really helps to co-finance the system by private contributions, but also to increase the awareness that healthcare is not for free.
In Ireland, I introduced what's called co-payments for pharmaceutical products. It started at 50 cents per item prescribed, and it's increased now to €2.50 for the items prescribed. It's capped at €25 a month.
So in a way, it's the entire paradigm of how do we pay for true innovation that needs to change. And in that, obviously, discourse, things such as do we continue with the criteria or inferiority compared to existing treatment? Do we continue to use that as a criteria for assessing the clinical impacts of innovations? But also, to what extent do we consider the budget impact?
40% of the population roughly have what's called a medical card, which allows them to get free hospitalisation, free GP access. They do have to pay the co-payment for pharmaceutical products, and the government are now rolling that out to all children under 6 and to everybody over 70. But everybody has to pay, subject to those with a medical card, the first €600 of treatment in a hospital, for example, or €100 if you go to an accident emergency department.
All those conferences are addressing the technology issues. None of them are really addressing the question of how are public healthcare systems adjusting to that change.
We are now having a discussion not about the treatment or the medicine in general, but for whom exactly would it be a profitable intervention. And that for one person it may not be cost effective and not effective at all, and for others it may be. So what we try to do is have a much more nuanced debate and a much more personalized debate about when to use this treatment for what specific indication and what specific groups.
How did you achieve your goals? What were the measurements you had to take and the actions you had to take? And what are some of the most important actions that you think were necessary to achieve your goals and your reforms?
Well, firstly, we assembled the evidence, and then we went about convincing people of putting the evidence into effect. You need champions. You need all stakeholders involved if possible, but you do need champions. You need patient champions, you need other stakeholder champions, and you need huge determination on behalf of the Minister and the Government.
Our first reform project was primary healthcare, the reimbursement system. We did it in close cooperation with representatives of all fields of primary healthcare, of primary care physicians, gynecologists, pediatricians, and dentists. With all these facets, we changed the way the reimbursement system was made and made it geared towards patient satisfaction and medical services delivered.